Well, welcome to the fourth year of the nationally recognized award-winning Conversation Series. This program will be a deep dive into palliative care, what it is, national trends, and what is available for you in the Metro Atlanta area. We will have two strong speakers on this topic. I am Richard Bressler, former board chair of the Weinstein Hospice Board of Advisors, having served as marketing chair from 2012 to 2024. And I'm also a former member of the Jewish Home Life Board of Directors. I'm a career healthcare marketer and community volunteer for the Weinstein Hospice, having graduated from Tulane and Northwestern universities. Weinstein Hospice is the palliative and end-of-life component of Jewish Home Life, an organization centered on aging which provides care for a new age. As the only Jewish not-for-profit hospice in Georgia, we tackle issues of community concern in a series of conversations. We've completed the production of 14 successful Zoom webinars for Weinstein Hospice, all targeted at generating awareness, promoting a conversation among the 45 to 60-year-old population in northern Metro Atlanta. The conversations are available for viewing at www.weinsteinhospice.com under the Resources tab. They're also available on our YouTube channel. This one will also reside there after completion. After this one, we have one more conversation planned through May of this year, and hopefully 4 more next year. I will now introduce our speakers. First, we have Rory Farrand, MA, MS, MSN, APRN-BC. With that many initials after your name, you have to be a well-educated professional. Specifically, Rory holds a BA from Edinburgh University of Pennsylvania, an MS from Washington State, an MA from Lesley University, an MS from Boston College, and a postmaster's degree from Cal State in palliative care. That being said, Rory is an accomplished senior executive and thought leader. She is currently a senior consultant for palliative care and the VP of Palliative and Advanced Care for the National Alliance of Care at Home in DC, formerly known as the National Hospice and Palliative Care Organization. She has varied experience in healthcare around clinical support and management. On top of that, she's published in a variety of health topics. When not working nor volunteering for several organizations, Rory enjoys painting, baking, traveling with her family, and her beloved French bulldog. Sharon Neulinger, MD, was born in Brooklyn, New York, and graduated from SUNY Downstate Medical School, moved to Atlanta in 1983 for her medical residency at Emory. While in training, she met her future husband, Dr. Richard Kaplan. They have 2 adult children, and Dr. Neulinger works full-time practicing internal medicine and palliative care for the Southeast Permanente Medical Group. She serves on the advisory boards of Weinstein Hospice and the Chabad in town. Details of Rory's and Sharon's bios are on your screen. So there are a lot of sleazy providers of both palliative and hospice programs. Our speakers are here to talk about how it should be a legitimate and not-for-profit answer for your loved one. We're going to start with Rory and go to Sharon. While they're speaking, please put your questions in the chat box and or the Q&A box. We also have Eliza Afra here from Weinstein Hospice to answer any really tough questions. But we should get to all the questions after the ladies have had a chance to speak. Rory?
Thank you, Richard. I appreciate you sharing all of that. Is Danica going to share the slides, or do I need to share?
Danica's going to.
You can share your slides. You have them.
Okay.
Right. Okay.
I'm not clear. Do I need to share?
Yes, if you want to control them. Yeah.
Got it. Okay. Just wanted to give me 1 second to get there. And again, thank you for that wonderful introduction. And I'm looking forward to chatting with everybody today. It'll take me just a second to flip this over, and then I'll get started with my remarks. Sharing. Oops, screens. All right, hopefully now you're seeing the slides. Can somebody on the Weinstein side show? Okay, perfect. All right. So again, thank you, everybody, and thank you, Richard, for that introduction today. We're going to talk a little bit about palliative care and how that can meet modern healthcare needs in the community. So I'm going to start us off with a super quick story. I'm going to talk to you about Laura, 72, who was enjoying her retirement until she noticed she was starting to have some difficulty keeping up with her friends when they were taking walks. She went to her primary care doctor, who opted to have her go to see a heart specialist, who found out that she'd had a silent heart attack. A few weeks later, she'd had another one and ended up in the hospital with heart failure. While she was hospitalized, a nurse came to see Laura. The nurse's name was Nicole. Nicole explained that she was a nurse on the palliative care team, which meant focusing on helping people live well, even with a serious illness such as heart failure. Nicole asked Laura what was most important to her about her care, and then arranged support that Laura didn't even know existed. That included giving her medications for many of her symptoms, including shortness of breath as well as nausea. The nurse even made suggestions that helped Laura be able to talk about her illness with her loved ones, including her grandchildren, and she helped arrange a social worker to provide support to Laura's husband. A few weeks after starting palliative care, while still learning how to live with her new diagnoses, Laura was starting to feel normal again and back to enjoying many of the activities that she used to do. Her husband better understood how to support her with her new illness, as well as how to take better care of himself, and her children, as well as her grandchildren, felt comfortable asking about her health. So this is really what palliative care can do. Think of palliative care as an extra layer of support, basically having your own personalized support team in your corner while you're dealing with a serious illness. The team's primary and sole responsibility is focusing on making you feel better and helping improve your quality of life, whether you're still receiving treatment for a condition or not. The key difference between palliative care and hospice is when you can receive it and what it's used for. So palliative care can begin at any time during a serious illness, much like the case that Laura had, where she was starting to receive palliative care as soon as she was diagnosed with her illness. Palliative care works alongside other medical treatments like chemotherapy, radiation, dialysis, all of those kinds of things, as well as have team members that can help coordinate care between all of those docs. It helps manage bothersome symptoms. A lot of people really struggle with pain, nausea, fatigue, breathing problems. One of the primary things we do in palliative care is help manage bothersome symptoms. Palliative care also provides emotional as well as practical support, not just for you if you're the one living with an illness, but the rest of your family as well. And it can continue for as long as you need it. That could be weeks, it could be months, it could even be years. And the biggest difference is that palliative care can be delivered while you're still actively fighting an illness and receiving treatment. In contrast, you're probably familiar if you've joined these conversations before that hospice care is a specific type of palliative care. But let me emphasize that not all palliative care is hospice. Remember, hospice is specifically focused for end-of-life care, typically when life expectancy is 6 months or less, and hospice focuses on comfort rather than curing an illness. Specifically, that means if you're receiving hospice care, you're expected to discontinue those types of curative interventions. So a lot of times people say to me, I've never heard about palliative care. Is this something that's new? Actually, it's not. Palliative care has been in the United States since the late 1970s. And really over the last couple of decades, though, it has seen significant growth across the country. At this point, most recent statistics report that 93% of palliative care can be found in hospitals who have beds that are at least 50 beds or more. So a lot of times we find that palliative care is delivered very frequently in hospitals, but not as frequently in the community, although that is changing day over day. So what I think is even more exciting is that palliative care is increasingly being incorporated right into the practices that you already see, whether that's your physician or a specialist like a heart doctor or a cancer doctor or things like that. It's something that's become a bit of a gold standard that whenever somebody has a serious illness, palliative care should be introduced right away. As I mentioned, there's sort of this growing emphasis on early intervention, palliative care being offered at the time of diagnosis. And studies have shown that palliative care often actually improves treatment and in some cases can actually increase survival. So part of the reason why we are seeing such a huge growth in the provision of palliative care has to do with changing demographics. I don't think it'll surprise anybody that's on this call to understand that our population is aging. And as our friends and colleagues get older, more of them are living with many chronic illnesses. 1 in 5 have at least 5 chronic illnesses. So that's a fairly sick population. But because of advances in medicine and research and all of those kinds of things, people who have serious illnesses, including things like cancer and other things like that, are actually living a lot longer than they used to. So that means that people who have multiple chronic illnesses, maybe a chronic illness plus a serious illness, their symptom management needs are quite complex. Additionally, I think this is a good thing. We're starting to see health systems focus on things like patient-centered care. I think as a patient, we probably always thought that care should be patient-centered, but it is becoming something that we're actually tracking and measuring, and there's a lot of attention on making sure that patients are at the center of care. But we're also focusing on improving quality of life. We know, if you ask probably anybody that you're friends with, somebody at least has pain that's poorly controlled. They probably have another symptom that's not very well managed. So we are finding more and more our friends, colleagues, and neighbors have an increased need for pain and symptom management. We know that costs are rising. You've probably heard the statistics that the US has one of the highest expenditures per capita as it relates to healthcare costs, but our outcomes are not particularly good. So we're seeing more and more organizations, both health programs, health systems, integrated systems, insurers, all of those kinds of folks are recognizing that we need to both improve costs, but we also need to better coordinate care. Family caregivers are probably the greatest group of unsung heroes in this country. And if you are in the position where you have to care for somebody in your family, it is a very challenging and burdensome role. A lot of us do it with love, but it's really exhausting. So we are finding that more and more people like me are in that sandwich generation, caring for an elderly parent at the same time having kids that we need to manage. It's a lot. And so we find that caregivers need attention as well. So palliative care can really be that bridge between curative interventions where somebody's trying to cure or get over a particular illness, but also when people aren't at end of life and maybe they're not yet ready for comfort care. So palliative care can sort of thread that needle between those two sort of disease or illness states. So when do you know that palliative care is needed? I usually say there's 2 indicators, and that's it, just 2. When somebody has burdensome symptoms and when there's caregiver stress or strain. So this idea that physical indicators such as, we talked about these painful, burdensome symptoms, pain, shortness of breath, nausea, all those kinds of things, that's a good indicator that palliative care consults might be warranted. The other thing is when we start to see our friends and neighbors having increased hospitalizations, for example, 3 times in the past 2 years, or even 2 times in the last 6 months, that's telling us that somebody is starting to decline a bit and they probably could benefit from a palliative care consult. We see our loved ones sometimes losing weight loss and they're not intending to. That often is an indicator that their illness is advancing. So that's a good indication that somebody may benefit from a palliative care consult. Living with multiple chronic conditions, or as I mentioned, like in the story with Laura, an increased need for help with daily activities. All of those things might be indicators that palliative care might be a good level of support for you. But there's also those quality of life indicators. Our human experience is not made up just by our physical experiences. We're emotional beings, we're spiritual beings. We have psychological experiences, especially if we find that we're in distress about our own illness, or perhaps we're feeling really burdened and overwhelmed by a loved one's illness. That's impacting our quality of life. So palliative care could be a good intervention introduced at that point. I talked a little bit about the unsung heroes, caregiver burnout, caring for somebody over many, many months and even years can be emotionally, psychologically, spiritually, physically exhausting. That might be an indicator that palliative care could be a help. Many times, families are scattered all across the country, and it's not easy to make decisions about our healthcare, especially when it comes to questions like what we would want to happen if something were to happen to us. For example, conversations around discontinuing certain types of care, or introducing CPR if someone's heart were to stop. All of those kinds of things, they are very complex. And there's a lot of things that go into those decisions. So the palliative care team is especially trained to have those kinds of conversations, both with the patient as well as with this extended family, even when that family is scattered all over the place. We see folks starting to sort of struggle with the activities of daily living, something like managing medications, or really struggling with treatments. Maybe somebody has gone to an infusion center for something, or they've gone to dialysis, and when they come home, they're just not bouncing back the way that they used to. That's an indication that the disease is probably advancing. And again, another indicator that palliative care could probably be a benefit. And as I mentioned, this idea about advanced care planning. Every adult should have an advanced care plan. That doesn't mean everybody needs a POLST or a physician's orders for end-of-life care, but everybody should have a conversation with their loved ones, no matter when, where, however old you are, or where you might be in an illness process, so that people know how you would want to live. Now, this should never be a one and done conversation. As somebody's circumstances change, for example, you have a child, or you have a second child, you become widowed, you get divorced, all of these sort of things that happen to us in our lives, or perhaps we have a new diagnosis. These are all indications that we should update, think about our advanced care plan, and make sure that our loved ones, as well as our physicians, know what our wishes and values are. I like to think that that conversation is actually a gift to our loved ones, because that takes the burden of the stress that happens when there's an emergency off of everybody else. My family knows what I would want in the event of an illness. I know what my parents, my husband would want. That way, whenever something happens and those people can't speak for themselves, I know what decisions they would make, and I feel very comfortable making those decisions, even if they're not ones that I necessarily would agree with, but it takes sort of that stress, strain, and burden of having that decision off of my shoulders. So a lot of times we hear various myths and misconceptions that are quite pervasive around palliative care. And I think it has to do with the fact that it's uncomfortable sometimes to talk about things like illness and progression of illness or recurrence, all of those different kinds of things. But a lot of times I hear things like palliative care means giving up. I like to reframe this. Palliative care is actually a very aggressive form of care. I like to say that we aggressively manage symptoms. We aggressively address your concerns and help take care of not only you and your loved ones. So while it can be provided alongside of curative treatment, it's not giving up. We take a very sort of robust approach to whole person, holistic conditions that make us who we are. So instead of giving up, it's actually kind of a really sort of aggressive, so I like to think hopeful approach to care. It doesn't surprise me a lot of times to still hear that people think that palliative care is only for cancer or end of life. That comes from the fact that when the hospice benefit was introduced in the late 70s and then written into law in the early 80s, cancer treatment was really kind of minimal. There wasn't a lot of things that could be done, and it literally the hospice benefit was started to support patients with cancer. And then, of course, over the years, more and more conditions were added. But I think that's one of the reasons why that particular misconception continues to exist. So let me reiterate that palliative care is beneficial for any serious illness and at any age. So I am a nurse practitioner who specializes in geriatrics and end-of-life care. But I have had 2 kids who had issues where they ended up in the hospital, and I know that there were palliative care teams even for young children. So anybody who has a serious illness at any age or any stage of illness, palliative care can be a benefit. The last myth I hear all the time is that palliative care hastens death. And like I said, there are numerous studies that show that palliative care not only improve quality of life, but in some cases may actually extend survival, even when delivered alongside of curative interventions. So before I hand things over to Sharon to talk about what's available to you all in your local community, I want everybody to think of palliative care as a service that helps you live better while living with a serious illness, rather than a service that means you're giving up on treatment. It's about adding to your care, not taking away from it. So as you go away home, you're already at home, I'm sure. As you discontinue this conversation later today, And as you talk with your friends and loved ones, I hope you remember these key takeaways. The growing availability of palliative care means that we are meeting crucial healthcare needs, and the benefits that palliative care can deliver extend much earlier than just care at end of life. There are many indicators for an appropriate referral, but if you only have to remember two, like I said, bothersome symptoms and caregiver stress and strain. That is enough to ask for a referral to palliative care. Again, palliative care can be delivered alongside curative treatment, and in fact may actually help you with that treatment. If you're feeling better, you're more likely to make it to your appointments, and your curative interventions are actually likely to be more beneficial. So you feel better, you're able to continue your treatments rather than having to skip treatments because you're feeling pretty poorly. Many doctors are still unfamiliar with the concept of palliative care the way I've described it to you. So if you feel the need that you or a loved one could benefit from palliative care, I would suggest that you don't just ask, but you demand to have a palliative care consult. And I guarantee that you will be very happy with that if you do. So at this point, I'll stop sharing my screen and I will hand it over to Sharon.
I just want to say before we move, thank you so much, Rory, but before we move to Sharon, some people are typing some questions in. Continue to type the questions in. When Sharon finishes, we will begin to answer those questions. Go ahead, Sharon. You're muted.
If my screen can be shared, and I have to apologize, I have influenza A, so my voice is raspy. Anyway, tell you a little bit about Weinstein Palliative Care. The program is over 15 years old. It was started as a pilot program financed by a grant from a private foundation to Jewish Home Life, and now the average census is 20 to 25 patients. Who we care for. We provide individualized care for patients with chronic and terminal illnesses. Examples are congestive heart failure, coronary artery disease, cancer, lung disease, including COPD, pulmonary fibrosis, interstitial lung disease, neurological diseases such as dementia, ALS, and other neurodegenerative diseases, and kidney disease. And these are patients who want to continue going to their doctor's appointments, get transfusions, get chemotherapy, get dialysis. They are generally willing to be admitted to the hospital if that is recommended. They do not have to have a finite life expectancy in the Weinstein program. Some palliative care programs want a life expectancy of a year or of 2 years, but Weinstein does not ask for that. And we don't expect the patients to be living forever, but even when a doctor has to certify for hospice that the life expectancy is 6 months, there is always wiggle room. If somebody is still sick and still needs it and they're not getting better, they can be renewed. Okay, the next slide, please.
Next slide, Danica.
What we provide. We provide regular visits from a palliative care nurse practitioner. The nurse practitioner works under the supervision of a medical director who's a physician. In addition to those regular visits, which are about once a month, but could be more if needed, or sometimes less, there are visits available from social worker, chaplain, and volunteers. What the nurse practitioner can do is help coordinate care among the patient's physicians, because a lot of these patients see several different specialists and they come back and, even with a good caregiver going with them, a younger child, or they come home and they don't quite understand what they were told. They get confused what Dr. A says and what Dr. B says. So the nurse practitioner can help sort things out. Sometimes the nurse practitioner will reach out to the physicians. And, even in our modern medical world with everything on the computer and all the medicine reconciliation, there's still times where people come like, oh, did you know patient was already on a medicine in this family? And the nurse practitioner can help sort that out. In addition, she can help with symptom management. If a new symptom comes up, she can address that. talk to her medical director or talk to the patient's other physicians. What we do not provide durable medical equipment, meaning things like hospital beds, wheelchairs, walkers, oxygen. Patients have to get that the way they would be getting it if they were not in the palliative care program. We do not deliver medications the way hospice patients can get their medications delivered. We do not provide nursing assistance to do things like helping with bathing, dressing, and activities of daily living. And we do not have 24/7 availability to contact a nurse, which hospice patients do. So I was just trying to show some differences between hospice and palliative care. And one thing is that many of our palliative care patients transition into hospice as their disease progresses. And I think it's helpful for them to be kind of familiar, not have somebody, like there used to be a little image that I have, they don't have anymore, which shows as a person's illness starts, their care is mostly traditional care and palliative care is a small part of it. As time goes on, palliative care becomes a bigger part and their traditional care is a smaller part. And then it's easier for them to transition into hospice. I as a palliative care physician, don't like it where somebody's going along for 2 years of treatment for a fatal disease, and all of a sudden their doctor comes and says, okay, we can't do anymore, now it's time for hospice. That is very hard. So I think palliative care offers a great service to many patients, and many patients don't know about it. And as Rory said, many doctors don't know about it. And I've been doing this for, 12, 15 years, and many doctors still think it's hospice. I know I don't want my patient to have that, and I've heard of doctors refusing palliative care. So you can demand it, but you might have to have some good luck, because not every, and when Rory's slide said the patients don't want to give up, there are some doctors who don't want to give up and are reluctant to do referrals. But thank you all for listening, and I hope you remember palliative care now.
Well, thank you, Sharon, and thank you, Rory. We've got a couple of questions that I think are all excellent questions. But first, I want to start with one about, the physician. And, you say the physicians don't know about it, or they do know about it, or they don't want it, or they do want it. Does it have to start with the physician? Would the physician ever, what would motivate a physician to say, hey, I think we need palliative care for this patient, and let's add a team? Does that ever happen, or is it really the patient demanding it from the doctor?
I think most of the time it's a physician who recommends it. I work a lot in the hospital. Many times it starts in the hospital with an inpatient palliative care meeting. And then, some of the questions that people have, there isn't that much palliative care available. That's what people don't know about, what palliative care is available. There is outpatient clinic palliative care where if a patient is well enough, they can go to see a palliative care physician or nurse practitioner in the outpatient setting. One thing about Weinstein that I don't think is true with other palliative care, many times people have to meet I think it's the Medicare definition of homebound to get palliative care in the home. No, you're saying no, Rory, because some programs I think do want the patient to be homebound, which is, and homebound means they're only getting out of the house to go to doctor's appointments or to church or synagogue or temple. But I guess that's not the case with most. Okay.
I think that you're absolutely right. That used to be the case, and it's going to depend too on the payer. For example, commercial insurances may insist upon that definition, but that's not something. It's not the standard. A lot of the patients that I saw on the house calls practice I was in were perfectly capable of getting out and doing all kinds of stuff.
So let's talk about the payer. There's been a couple of questions about insurance. Does insurance cover it? Is it a fight to get insurance to cover it if they're not already covering it? That kind of thing.
Yes to all of those. So insurance does cover it. Medicare covers it, Medicaid covers it, commercial insurances cover it. The question around how much of a fight is going to depend on the insurance product that is being used. So it is covered under the physician's portion of Medicare, Medicare Part B, without any kind of pre-authorizations, those kinds of things. Commercial insurances, they cover it, but they may have specific, as Sharon mentioned, they may have specific rules around what they cover. So it's something that you can ask your the customer service line if you actually can get to a human and not a bot at your insurance to if that's something that's covered. I think that where the fight comes sometimes is more what what Sharon had just said, that this concept of physicians not wanting to give up and still holding on to that misconception that palliative is just for end of life. And I think I've said this to Richard before, I blame ER, Grey's Anatomy, any medical show on TV, because what they always say is there's nothing more I can do for you. Let me consult palliative care. So, you know, popular media has continued to sort of extend this sort of misconception around palliative being just at end of life. And so every time they say that, my husband can hear me screaming from the other room, you know, how mad that makes me. Which is why I like to describe it to you as this idea that it is a very aggressive modality, because it's something we do. We really work very hard to address all of the things that make us human, the physical stuff, the emotional stuff, the psychosocial stuff, the spiritual stuff, all of those things contribute to our human experiences. And that's what we as palliative care can do, is we kind of address this holistic modality. So again, to sort of go back to the payer, I hate to say it, it depends, because I feel like that's a cop-out answer, but that kind of is. But if you have Medicare, if you have a provider that does community-based palliative care, meaning outside of the hospital, you absolutely can get it. As Sharon said, a lot of times palliative care starts in the inpatient setting. A physician makes that recommendation, or somebody, a social worker on the team, recognizes that somebody has a need. And I always say that if you had a palliative care consult in the hospital, your need didn't just magically disappear when you got discharged. You know, you probably have the same need when you go home. So if you or a loved one has a consult in the hospital, when thinking about the discharge plan, is there palliative care available to my loved one? Who provides it? Where would I get it? Those kinds of things.
Yeah.
I have a question for Rory. And when private, non-Medicare, non-Medicaid, commercial insurance, do they work with certain providers? And if you have United, might they say you can use this provider? So sort of like everything else with insurance.
Yeah, just like anything else. If you're in network, it's great. And if you're out of network, you can have the, the 80%, 20% co-insurance, all that kind of stuff. But yes, you can have palliative care physicians and nurse practitioners in network. And obviously they like those folks. But, it's just, commercials always challenging.
And another thing I wanted to say, something that, and patients will come to me and they said, well, they said there's nothing more we could do. And maybe there's nothing more we could do for the disease, but we can do a lot for the patient and family. And I never know if somebody really said that to the patient and family or if that's what they heard, but that is not a good thing. And the other thing about palliative care, I understand if you Google palliative care, what comes up is hospice. Yeah. So when people, even the hospitals see, here they're getting a palliative care consult, and we call it, early on, upstream, get to know, they're like, oh my, so we always have to go in and explain that we're not hospice.
Well, I personally love the word palliative care. I think it palliate, to alleviate. I think that the word explicitly describes what we do, but you may actually have heard of palliative care as described as supportive care.
Some hospitals, Sloan Kettering, I think, calls it Memorial.
Supportive care. We hear that a lot, sort of in the clinic setting, like the oncology clinics, renal clinics, those kinds of things. The service that I worked for, one of our insurances insisted that we called it advanced illness management. Everyone else in the company, we called it palliative care, but that's what they asked us to message their patient when we communicated with that particular programs.
To further confuse that, our provider, Weinstein Hospice, certainly provides hospice care, but it also provides as a separate service, palliative care. So it's two distinct different service plans, service products. Sharon talked about what you can and can't get under palliative care. What about OT and physical therapy and speech therapy and those kinds of things? Can you get those things?
It
You
can
could
be
get
delivered alongside with that, yes.
But not
The-
with hospice. The question there says
Oh,
hospice.
oh, does it? I'm sorry, my bad. Go ahead, you can answer the hospice question.
Yeah, I mean, generally not with hospice. What happens with hospice is that the hospice gets the patient's money. You know, the hospice becomes the provider. Now, if somebody is on hospice for something and breaks their leg, they probably can get physical therapy for their broken leg. But if they're having general decline and just to see if they can get a little stronger, generally not, because hospice would have to pay for that, and Rory, you can correct me if I'm wrong, out of their per diem, and they just don't get enough money to do that.
Yeah, if it supports the sort of, if it's part of the person's plan of care, hospices, some hospices do provide it. But as Sharon was saying, it comes out of sort of the daily rate. As it relates to palliative care, yes, you absolutely can receive any of those types of therapeutic interventions while still receiving palliative care. Again, that's going to be insurance payer specific. How many treatment, usually PT is what, 26 treatments over X period of time. Co-pays probably apply, especially to, any specialist, and palliative care is a specialty. So again, the limitations are going to be basically payer specific. Home health, a lot of times home health is paid for under Medicare Part A. A lot of times they are providing skilled therapies. Sometimes they don't, they get confused around the paying, the payer aspect, and they'll say you can't have home health and palliative. You absolutely can, because they're two different billing mechanisms. So push back if you ever get the answer that doesn't seem particularly positive. Because there's often ways to work around it.
So what if the person, again, talking about palliative care, what if the person has cancer, but not stage 4 cancer, and is, let's say, bleeding and needs a transfusion? Can you get that on palliative care?
Yes.
Does the transfusion make them feel better? Yes.
Okay.
So, that's the idea, is that you can receive palliative, the person's getting curative interventions. There's nothing that says that they can't have palliative at the same time. I have seen many patients feel poorly while getting their chemotherapy treatments, for example, and so sick that they miss the next treatment or they miss the one after that. And statistically, odds go down when you aren't actually able to maintain the treatment regimen that's prescribed for you. So what palliative care can do is help you feel well enough to get to those appointments so that your outcomes are improved. So I've had plenty of patients have blood transfusions, getting, dialysis, all of those curative interventions. I mean, you can have all of those kinds of things if that's part of your treatment plan. And if you, like I said, burdensome symptoms and caregiver stress and strain, those are sort of the two indicators.
Yeah. Do you have to have a referral into palliative, or can you just pick up the phone and call them and say, come on?
Insurance dependent. So, for example, if you have Medicare, straight up Medicare, not a MA plan, and you happen to know, for example, Weinstein Hospice has a palliative program, you might be able to call and request it. I'm sure that there's an admission thing that, and Eliza probably can speak a little more to this, but you probably have to meet certain criteria to receive that. But I've had plenty of patients call and self-refer, refer for a loved one. Physicians can do that. So again, I hate to say it depends. It's most likely payment specific.
Okay. Eliza, do you have a comment on that?
Okay, I was just going to say we do need physician orders. So a doctor would have to order palliative care. But yeah, I agree with Rory. A referral could be dependent, but we do need doctor's orders to start the process of palliative care.
And the
Okay.
doctor can't be your medical director. Is that correct?
I'm sorry, Sharon, say it again.
The doctor cannot be your medical director.
If he's your doctor, there's
Okay.
I do have some patients that our
Okay.
medical director does see, so he can.
Okay, but it has to be someone who has a relationship with them.
Yeah. ideally.
Is most treatment facilitated by a nurse practitioner, not a doctor?
That's going to depend on the setting.
Right.
So hospital-based palliative care, I like to say it's dealer's choice, honestly. A palliative care team ideally mimics that of a hospice team. So you have a doc, a nurse practitioner, an RN, a social worker, a chaplain. You have all of these folks involved. But depending on who's paying for it, it could pick any of those combinations. It could be any of those depending on who's providing it. So the program I worked for was a full interdisciplinary team. We had a medical director, nurse practitioner, RN, social worker, chaplain. I have supported as an operations leader programs that are just an RN and a social worker, or an NP and a social worker, or an NP and a doc. So it really can be anything, but the whole team is responsible for developing that plan of care. And the question around facilitation, a lot of times it's us nurse practitioners or the RN that comes to the home. Doesn't mean that the doc can't, doesn't mean that the other team members can't. But in a home-based or community-based palliative care program, if we're coming to you, it's going to be whoever you need at that point that's going to show up. And if you're receiving palliative care, for example, in a clinic or in an office setting, you might see the doc, you might see the nurse practitioner. So it really can be any of us.
Okay. It's a question about whether you have to be Jewish to use Weinstein. And I would like to respond to that. And that is that Weinstein is a Jewish hospice, but it's because the people that own it and provide the care are Jewish and therefore want to take care of the general population. But no, you do not have to be Jewish to use Weinstein. Did I say that right, Eliza?
It was perfect, Richard.
But not
Okay.
all the people who provide the care are Jewish,
That's correct.
as you said, right?
But
And a lot-
the company is owned by Jewish people and such like that,
okay.
even though it's a not-for-profit. So, and how do you get the services and help you're talking about if they only come once a month?
Do you want to answer that locally, or do you want me to answer it sort of nationally?
Let's do both.
Okay,
Rory?
so from a national perspective, very similar to a hospice plan of care, we come as frequently as is needed. So sometimes patients need to be seen weekly. I've had patients during a crisis that need to be seen multiple times a week. We come when is needed. Generally, as somebody's illness is progressing, the frequency tends to increase. But I've also had patients on the flip side who we saw every 6 weeks. 6 to 7 weeks, every 21 days, all kinds of stuff. So it's dependent on what we're doing. Did we introduce a new medication? Are we following certain treatments or labs or things like that? We come as frequently as is needed. But some programs are very strict and they only show up once a month. But from sort of the national sort of big picture perspective, it's need-based.
And let's answer locally as well. Is that Sharon or is that Eliza?
I'll leave that to Elisa. Sorry.
I was going to say with Weinstein Palliative, it is individualized. So it goes based on the patient's needs. I've had patients, like Rory had said, that I see multiple times a week. And then I've had other patients who say, you know what, Eliza, I've had so many doctor's appointments this month. Can we do it 6 weeks apart instead of every month, right? So I like to say that it really, truly is individualized and caters to what my patients need.
And I would say too, depending on your program, Eliza, if you have a social worker, maybe it's not you coming out every month. Sometimes people get out of the hospital and they're okay, they're stable medically, they're seeing their regular physician, they're seeing the other specialists, but they have social needs, for example, disability paperwork or applying for Medicaid or getting connected to community resources. And the social worker might need to come out or connect or telehealth or more frequently sometimes than the medical or the nursing side. So again, it really depends on where you are and what you need at that point in time. Sometimes when folks are making a decision between around advanced care documents, and maybe they're deciding that instead of being instead of wanting resuscitation, they've decided that they no longer want it. that's really stressful to them. The family's struggling with that. Maybe the social worker, sometimes even the chaplain can come and sort of facilitate those conversations. So it really is, you know, I like to say really meet people where they are. It sounds like sort of a cliche setting, but I like to say that we walk alongside our patients and families. We don't try to drag you down any kind of particular path. Whatever you need, we will figure out a way to sort of make it happen.
I love that, Rory. That's what I tell my patient. I actually just told a patient that today. I said, you are the captain of the ship. I'm here as your support crew. I'm here to, your resource and your support, and helping you navigate this journey in whatever way you want this to look like. So I agree.
I love that.
So patient is about to get out of the hospital, about to be discharged. Is that the best time to request palliative care from the physician if they're not?
Oh, I hope that
suggesting
that's
it?
been requested already a week ago, so this is why I made the comment about you need to kind of ask or demand for palliative care. So we actually track in our hospital-based programs how quickly palliative care is consulted from the time that person walks in that front door. So they come in through the emergency department, they are in crisis, something's going on. The best case scenarios are going to be that consult is made sometimes in the ED, as soon as that person hits the ICU, as quickly as possible. We can provide so much more support and help if we've seen that patient early and can help sort of guide that treatment plan. It's really hard as a clinician to see a patient who's been there for 3 weeks, and there's a lot going on, and maybe they've received a bunch of interventions they didn't want. The choices were sort of foisted upon them that they wouldn't have asked for. We can help even during a hospitalization as soon as possible. So like I said, I'm a palliative care clinician. When my father-in-law was hospitalized with sepsis related to his terminal diagnosis, you bet you're behind that I was up in everybody's grill that he needed it ASAP. And I kept getting this, oh, he's not there, he doesn't need it yet. And this is a major medical system in my city that has one of the best palliative care programs in the country, and they were pushing back. So you just be that little bug in somebody's bonnet, and until you get the consult. And we're not going to force treatments on you either. If we come in and say, oh, you don't need that, we'll do our consult and we'll go away. But you're not going to know until we come in and check you out.
But given the hospital setting, it seems that the referring physician could be the hospitalist or whatever, if not necessarily your primary care physician.
Exactly.
Because
a lot of times your primary care doc doesn't even know you're in the hospital. So you need somebody to advocate for you or your loved ones. So yeah, as soon as something is going on, that someone's struggling with symptoms or it's a new diagnosis, ask to have the palliative care team come and talk to you.
Okay. Well, I think we're just about out of questions here, because I think that these two ladies have answered everything. These three ladies, I should say, have answered everything and then some. But if you think of another question after we hang up today, you can send an email to us and we'll be able to answer that. I believe our both Rory and Sharon's contact information is going to be on the next slide. And if not, you can contact Weinstein Hospice and we will we'll get that question answered. We have another webinar coming up in about 2 months, another conversation about elder care and guardianship, and that should be interesting as well. So I think we're getting in different, yes. So here's Rory and Sharon's contact information.
I can type my thing in the chat, because my contact, if I can figure out how to do it, because my contact information isn't there. So I will just try to type it in the chat. Let's see.
Richard, is this slide on the screen the one that's coming up next?
Yes. Yes. But Sharon's contact information is sharoneu@comcast.net. And Eliza's contact information is at Weinstein Hospice. And Eliza, do you want to share that in the in the chat as well?
Sure. Let me see if I could figure out how to do this here. There you go.
And there's Eliza's contact information as well. Okay. Our next one is May 16th. And that's the next conversation about guardianship, how and when is the right time. And hope to see most of you there as well. But thank you all for attending. And if any questions come up, let us know. But thank you.
Thank you.
Thank you for including me, Richard.
You.